Hey, my name is Henrik. I am a PhD student at Erasmus University Medical Center, and I'm presenting on external validation of existing dementia prediction models. And this is actually a project that I am currently working on together with Jan Kors, Jenna Reps, and Peter Reinbeck. Yes. Okay, so at Erasmus MC, we already have for some time been looking into the possibilities of developing our own dementia, late life dementia prediction models, I think for a year already. And the reason that we actually put this on hold for the moment and are now instead looking into externally validating already existing models comes from a number of different papers. The first one is this one from 2016 by Richard D. Riley, titled External Validation of Clinical Prediction Models Using Big Data Sets from eHealth Records or IPD Meta-Analysis. And basically what Riley says is the following. Unfortunately, most prediction research focuses on model development, and there are relatively few external validation studies. This leads to a plethora of proposed models with little evidence about which are reliable and under what circumstances. Confusion then ensues, promising models are often quickly forgotten, and of more concern, many models may be used or advocated without appropriate examination of their performance. So basically what Riley is saying that developing your own clinical prediction model is just much more popular, just more attractive than externally validating them. And as a result, we end up with a bunch of models that we know perform really well on their development data sets, but well, we don't really know how well they would transport or generalize to other data sources out there, and therefore it's very difficult to assess their clinical usefulness. Well, for this study, we're specifically interested in dementia prediction. And there are actually two systematic reviews of dementia prediction models that I guess very much agree with what Riley says. The first from 2019 by Jan Gorten, titled Statistical Methods for Dementia Risk Prediction and Recommendations for Future Work. And yeah, well, the authors mentioned in the discussion that they identified three major methodological weaknesses. The first one is an over-reliance on one data source, then poor verification of statistical assumptions of cost and logistic regression, and lastly, a lack of validation. And they recommend the use of larger and more diverse data sets, which again is, I guess, very much the same notion. And then in 2019, there was actually another systematic review by Howe titled Models for Predicting Risk of Dementia. And here they also concluded that many risk prediction models have been developed, but actually only a handful of them have been externally validated. The predictive ability of the existing dementia risk models is acceptable, but the lack of validation limited the extensive application of the models for dementia risk prediction in general population or across subgroups in the population, well, which again is the same message. And basically, based on this set, these two systematic reviews, and then also based on Riley's paper, we actually defined the objective for this study to be as follows. So we would like to externally validate already existing prognostic models that predict late life dementia in the general population. And we're going to do this using observational health data from claims and EHR. And because this is a bit less of a clinical study and a bit more of a methodological one, we're actually not going to assess really the clinical usefulness of these models, but we are rather going to review the quality of model reporting in the past 5 years. Well, our starting point is a review, which was conducted by Jan Kors, where he looked at late life dementia prediction models from the past well, actually initially past 10 years, and then eventually we included papers from the past 5 years. So between 2016 and 2020, and in total we selected 28 studies that proposed 55 different models. We also compiled a list of information that we believe these studies should report in order for us to be able to replicate the models and then also externally validate them. For example, the development database would be nice to have. So is this data claims data, GP data, or EHR data, hospital data? And then also what the source data model is. So was it ICD-9, ICD-10, read codes, etc. Then the algorithm, of course. We actually, for now, limited ourselves to logistic regression and Cox proportional hazard models. Then coefficients, predictor definitions, the predictor time window. So basically, the predictor time window is the time at which, in which this predictor is assessed for a certain patient. Intercept and baseline hazard, of course, for logistic regression and Cox proportional hazard models. Then the target and the outcome definitions, the index date. And what we're doing at OHDSI is that we have the index date already as part of the target population, and then the time at risk. So a time window in which the model's predictions are actually valid. And in a sense, this information is not really different from what we're already using within the PLP package when we're developing our own models. Well, interestingly, in the end, none of those models could actually provide all of this information. But there were a few that, first of all, were developed on observational health data, and then second of all, could provide quite a large portion of the information. And then basically we were kind of forced to fill in the blanks for these models. Those models were the Walters Dementia Risk Score from 2016, which was developed on Fin data. Then Meta's RxDX Dementia Risk Index, also from 2016, which was developed on CPRD data. And then Norris Dementia Prediction Model from 2019, which was developed on Optum Labs data warehouse data. And again, so we didn't select these models because they perform well on their development data, but because they were well reported. So that made it easy for us to replicate them. So we replicated the models and we validated them in 5 databases so far, and this is still ongoing. But we have some preliminary results for MDCR, IQVIA Germany, Optum SES, and Optum Panther, as well as IPSI. And we're planning to also validate them on IMRD, which was formerly known as FIN and CPRD. And actually, the reason we are including these 2 databases is because the Walters model was actually initially developed on FIN data, and the Meta model was initially developed on CPRD data. And I think it will be interesting to see how these models will perform after they have done this round trip from being developed on a database, then being reported in a journal article, and then replicated by us, and then again applied to their initial development database. So these 2 still have to be approved and validated. Then the first column, this is basically the internal validation performance. So discrimination is as AUC, and calibration was reported with different metrics. For example, the Walters model reported the calibration slope. The Meta model used the Hosmer-Limshow chi-square test, and their assessment was that calibration was poor. And then the Norrie model, they just didn't report any calibration. And for that reason, what we're actually doing, we're using the e-statistic. And the e-statistic is basically a single value metric that assesses calibration, and smaller values, so values that are closer to 0 are generally better, well, are always better. And in addition, we're also recalibrating these models. So we have the e-statistic of the original model, and then the e-statistic of the recalibrated model. And well, for the Walters model, the internal AUC was 0.84, and for MDCR, we had 0.7, 0.76 for IQVIA Germany, 0.71 for Optum SES, and 0.73 for Optum Panther. And this is generally what we see most of the time, not always, is that the performance will just slightly drop as compared to the development database. Well, the calibration, of course, we can't really compare because we have different metrics, but what we can see is that after recalibration, this metric actually improves. And that actually also tells us that if we're externally validating, it's probably a good idea to also recalibrate our models. So this has yet to be run. Then for the meta model, the internal validation was 0.8. And then the external validation again showed very much the same pattern, that the performance dropped slightly. The best was the performance on OHDSI, which was actually very close. And that was probably because they're both, I believe, GP databases. And the reason that we're actually here not reporting the E-statistic is that the meta model, which is a Cox proportional hazard model, did not report the baseline hazard. And without the baseline hazard, we were then not able to assess the calibration. And then the NORI model, which already internally didn't perform that well with a 0.69, again, loses a bit of performance, just a slight bit. So the idea of this study is then, as I mentioned, actually going to be to review a bit the quality of reporting. And I think this is going to be a bit out of scope for this presentation, so maybe I can present this again in the future. But basically, just to summarize this really, really briefly, what we see is that the development database is basically always reported. So is the algorithm that is being used. Coefficient values and predictor definitions, which are of course very important to replicate our model, are mostly reported. Unfortunately, the predictor time window is very rarely reported. And this is a bit of a problem because it can make quite a difference whether you assess a predictor 1 year before index or 10 years before index. So it can very easily happen that a person goes from smoker to non-smoker in that time, or from diabetic to, or from non-diabetic to a diabetic, or things like that. Same for the baseline hazard and the intercept, that is not well reported. And this is very important to assess calibration. Then what we have always seen was the target and outcome definitions. And again, the index date was rather rarely reported. And the problem with this is that while you know very well for what population this model is supposed to be used, without the index date, it's very hard to tell when it should be used. For example, should it be used during a GP visit, or should it be used when this person turns 60? These things are actually not well reported from what we have seen. And then again, the time at risk, which is mostly reported. Well, to conclude, well, model reporting is often not complete, and we believe that the reported information could, in cases, be more explicit to make replication more easy. And in any case, we think that this study will actually set us up nicely for the future when we are going to develop our own dementia prediction models, with the goal of having models that transport well